Namaskar. We welcome all our very distinguished and very beloved champions and legends from what I call as Simply South. DIPSI, the organization where the thought process started with one great thought from one great individual, Padma Shri Dr. V. Sheshaya, who went into the depths of the matter concerning diabetes and pregnancy. From there, ladies and gentlemen, we've come a long way and we invite you to the world of insightful deliberations and meaningful reflections on the 14th of November, the World Diabetes Day, which is also fondly called the Children's Day in our own country. Well, we want the children, the generation next, to be free of diabetes. And that is the fresh thought and new frontiers that we are getting exposed to by the same gentleman, the Pitamaha of diabetes and pregnancy, that is Dr. V. Sheshaya. Can we have his address on the video, please, Chitrakala?
Dear President of DIPSI, Dr. Ahmed Walker, Secretary General Dr. Vijay Balaji, and all members of the DIPSI and office bearers, ladies and gentlemen, I am very happy to give this message on the day of International World Diabetes Day. So I thought we had done a work so many years in this field from 1980. What success we had, I want to share with you. You all know about that. Our Make in India guidelines contributions was to introduce a single test procedure to diagnose GDM. This test happens to be very simple, economical, and evidence-based, and the Government of India has recognized it in 2014. Again, it was again published in 2018. So all over the country, I wish they are following this DIPSI guidelines, which is a simple guidelines, a single test procedure. Now this is our first success in the career of the DIPSI. Now, recently, Dr. Ahmed Walker has told me and Anil Kapoor told me that they were in the FIGO conference in Latin America. They have also accepted to use single test procedure all over the most of the countries feel that it is very simple and doable test even during the COVID time. So it is a very simple test. Now, at present, the problem.
Yeah, so this is the initial thought that Professor V. Sheshaya has placed ahead of us, that decades ago, the work started and evolved into what is pragmatic, practical, and feasible in our country, and the single-step test came to stay. Before I go on to the first round of questions for Anil Kapoor, I need to release the chairman of KCOG, Karnataka College of ONG, Dr. Muralidhar Pai, who has so graciously joined us from Cloud 9, because he is flying from Bagdogra to Siliguri or some place high up in the mountains. So before we lose the connection, we want him to just give one message to the audience here. There, even as recently as the last 24 hours. There was a section of the faculty from the diabetologist group said that if you test each and every pregnant woman, that is universal testing, you are going to pick up a whole lot of them whom you're going to label as GDM and provoke a lot of anxiety. So, Dr. Pai, should we go back to selective tests, or the guidelines which we have so emphatically instilled into the government recommendation, the universal testing of each and every pregnant woman in our country? Why should we be doing that? Murli.
Thank you, Dr. Hema, for this wonderful initiative that you are actually continuing, which was started by the great one and only Professor Sheshaya. Yes, your question is very pertinent. What I would like to highlight is that the principle of screening is very clear. If a disease is highly prevalent, then there is absolutely no need to do screening. You can straight away do the diagnostic test. If a disease is very rare, then it is a waste of time and money. If the disease is moderately prevalent, it is moderate risk disease, then universal screening is a must. And we all know that India is a moderately risk country for diabetes in general, as well as GDM. That's exactly why it is absolutely requirement, and it is in place, that we do universal screening of all pregnant women. And now that we have a very simple test, it should not be difficult at all. It is in line with the principles of screening test as well. That's all I would like to say.
Thank you, Murli. This is a clear message once again to many in our own country, the frontline healthcare providers and the OBGYNs who have not yet taken up to the universal testing. Please, every single pregnant woman has to be tested. And can I just follow up with one question to Murli? What is your message to all the women out there in this great country?
Yes, I request all women that in the interest of yourself, in the interest of the baby that is going to be born, a strict control of sugars during pregnancy, especially in the first trimester, is paramount. We can't overemphasize that. So before you think of pregnancy, in fact, your sugar should be under control. To be precise, the glyco-HB or HbA1c, what we call, should be less than 5.9, so that the babies will not have anomalies. So please, and go ahead and do at least once the test. Insist on your doctor that whether the doctor has prescribed the testing or not. And please remember the word DIPSI. It's a very easy terminology. You educate your neighbors, your friends, and insist that they ask their doctors to do this test. Thank you very much.
Thank you, Murli. As the chairman of KCOG, which is academic wing of the Karnataka ONG Society, with the chairman, Dr. Muralidhar Pai, and the president-elect of Kasoga, Dr. Vidya Tobbi, the secretary, Dr. Bharti Rajshekar, and the whole group of eminent faculty from the DIPSI group, and the one who has put us all into the right channels of action, the chairman of WDF, Dr. Anil Kapoor. May I request all of you to join us in launching the e-certification course from DIPSI and KCOG Kasoga. Thank you very much. We wanted to do this as quickly as possible. All the distinguished faculty here, once again, a heartfelt thank you to all of you who have been with us through the whole of the last decade, going from place to place, city to city, town to town, metro or the smaller towns, deliberating the important messages on the management of gestational diabetes mellitus in a certification course which was done physically. Now, the COVID has changed both our attitudes and mindsets, and the ease of doing the education, the joy of learning virtually brings you the e-certification course. Many of you will yet again be requested to be the faculty, but this time absolutely at your convenience with the 12-minute recorded message, the deliberations which we are going to be shortly putting together. And everyone who registers for this e-certification course will review this at their own leisure and key in their questions, which are our frequently asked question series, which will bring the expert faculty live to you once in 6 weeks to have a face-to-face virtual discussion and iron out all your doubts, so that at the end of 3 months, when you have the exit exam, we have no doubt that you will excel and proudly carry the certificate of confidence and competence to manage a case of hyperglycemia in pregnancy. With that, we swing the question to none other than Dr. Anil Kapoor, who is a mix of science, art, and philosophy, if I may say, and very beautifully, he had deliberated on few of the concepts, which I would want him to tell a larger audience. One concept was the karma theory, that what goes in should come back to you, and how from the mother to the baby and generation to generation, the hyperglycemia and the programming is transmitted. The second he always mentions is, this is your chance. Nature has thrown a spotlight on few of the women out there in the population who have taken the stress test in pregnancy and failed and declared to be cases of hyperglycemia and pregnancy. So keep a watch on them forever and forever. And lastly, the linkages. GDM today is NCD tomorrow. All of these concepts, which were really remote to the OBGYNs, are now the mainstream of our own thought processes. And I really want the expert in Dr. Anil Kapoor to elaborate more on these very issues. Anilji.
First of all, greetings to all of you on the World Diabetes Day. The issue that Dr. Hema Devakar mentioned about the linkage with karma, basically, if you look at genetics and epigenetics, epigenetics is nothing but karma. It is how we live our life has an impact on how the genes get programmed. And that's an important concept for us to understand, that philosophy links with science. And it is the karma of our great grandparents, parents, that actually determine who we are and who we become. There's a saying amongst the indigenous populations that any action you do has consequences for 7 generations. And the indigenous people were are actually quite aware of these issues. And in the similar vein, it is important for us to understand that what the mother eats, what the mother's health is, has consequences in fetal programming and in developmental origins of health and disease. And therefore, it is the karma of the parents that impact the child and the future generations. And so that's how I try to link karma with epigenetics in a way. The other issue that you mentioned about the spotlight. So the thing is that in many countries, and particularly our country, women hardly ever get to access healthcare. Pregnancy is one time that Fortunately, now I would say that 80 to 85% of women in India are getting access to a health system. And it's a huge opportunity for ensuring that we are able to test these women for the health issues that they may have. And one of the key issue is, of course, hyperglycemia in pregnancy. So the issue is that having diagnosed hyperglycemia in pregnancy is one part of the story. For me, 2/3 of the job is subsequent to the diagnosis of hyperglycemia in pregnancy. And so what I say is that nature has put a spotlight on this woman. She has been identified as somebody who is at very high risk. And unfortunately, we let her walk away from the spotlight after the pregnancy is over. We do nothing to follow them up. We do nothing to follow up their offsprings. And this is a huge opportunity for addressing prevention. I'd like to, Hemaji, add a third dimension to this spotlighting.
Yeah.
That often we have found in studies that we talk about family history of diabetes as one of the risk factors for gestational diabetes. But we have realized that the linkage is much more with the mother. So in one of the studies that one of the PhD students did, and Dr. Seshaya was part of that, is we found that in Chennai, the study showed that whenever we talked about family history of diabetes, we found that despite the fact that less mothers had been tested for diabetes, more fathers of these women had been tested, but the linkage with the mother's history of diabetes was 3 times higher than the linkage to the father's history of diabetes. So I would like to add a third dimension, that if a woman is diagnosed with gestational diabetes, please make sure that you tell her to get her mother tested. Maybe she would discover an undetected diabetes because of the daughter's gestational diabetes. So that's another dimension that we need to look at. And therefore, keeping the spotlight on this woman, the index case of gestational diabetes becomes very, very important. We should not let these women walk away. It is a bridge that provides us, and in that context, I always talk about how can we do this follow-up. It is very difficult that after the pregnancy, the woman is not diabetic, she is not pregnant, so she's not going to the health system. No, she is going to the health system. She goes there with her baby for the vaccination program, for the Well Baby Clinic. And it is how we can provide that link. So I often talk with my obstetrician colleagues that Indian women put a bindi on their forehead, take the bindi of the mother's, from the mother's forehead and put it on the child's card to make sure that that child is then identified as a offspring of a mother with high risk. And so every time the child is brought in for the vaccination program, there is an opportunity to talk not only about the health of the child, but also the health of the mother. And the nurse or whoever paramedic is there could weigh this woman, could talk 5 minutes extra to her about why it is important for her to lose the weight she has gained during pregnancy, why it is important for her to eat healthy, why it is important for her to breastfeed the child, not only for the child's sake, but for her own sake. And the longer you breastfeed, the lower is the risk of developing diabetes in women who have gestational diabetes. And these are things that have been shown scientifically right, that the longer breastfeeding is, the lower is the risk of developing type 2 diabetes in the mother for a woman who has had gestational diabetes. So these are two important things that I would like to focus attention on.
One last short message, like how Muralidhar gave to all the women in the country. I want a message from your end to the government and the policymakers. What is the next best thing they should do?
So I would say that my message is to all obstetricians and to all public health system that having identified a woman at risk during pregnancy. And it is not just gestational diabetes. It is women who deliver preterm births, women who have preeclampsia or any other pregnancy complication. Let us start a new transformation of health in terms of following this mother and the offspring and creating databases to identify future generations that might be at high risk so that we can do preventive actions and target these children who are born to women with high risk of complications in pregnancy as really somebody that needs preventive care and greater attention so that we can reduce the risk of NCDs developing in these offsprings.
Excellent. Thank you, Anilji, for being present here and your precious time as well. Because I feel that all OBGYNs, the large chunk of their practice, it's obstetrics. And then the next large bracket comes perimenopausal when they have menstrual issues, hysterectomy and things like that. But during this gap in their journey, every year we have enough and more obstetric cases who have hypertensive disorders and hyperglycemia. If all those come for an annual checkup, that is a continuum of care and the enhancement of the practice as well under the bracket of women healthcare, because we need to see them, we need to have the preventive care, and we need to carry on the mission of doing our best at the earliest. So with this, I think Dr.
I just wanted to add one more thing.
Ji.
We are only talking about type 2 diabetes and risk, but the risk for cardiovascular diseases in women who have had gestational diabetes is extremely high.
Huge.
And we are going to witness a massive increase in cardiovascular diseases amongst women 10 years from now because of the fact that we are not paying attention to women's health during pregnancy.
Yeah, because, these issues of hypertension, diabetes, etc., somewhat were seemingly disconnected to the obstetrician's purview, but now we are like well into the thick of it. And I think we really need to pay serious attention to this continuum. I think Dr. Kasturi
we should change over from being obstetrics and gynecologists to being women's health experts.
Yes, because that's why I said that women healthcare, because just imagine the volumes that will be added to the practice every year as a separate vertical segment of checking out their wellness, which gives enough opportunities not only for these, but also early detection of cancer and routine other tests that we have to institute in these women. So that is something that we will figure out a way how to propagate that. So thank you very much once again, Anilji. And I think Dr. Kasturi Thonimat, the president of Kasoga, is also here. Welcome, Kasturi. My next question goes to Bharti first and Kasturi next. Bharti, Murlidhar Pai, the chairman of KCOG, very coolly said, whole universal, everybody should have the testing done. From selective to universal testing, how far have we come in achieving a change of mindset of everyone? The patients may also protest, no, my mother doesn't have, apne khandan mein nahi hai, and then why should I get this unnecessary sugar test done, and I'm like not even obese, and that may be patient's story, but the many heads of Department of Public Institutes have seen, no, let's only select those, we cannot test this whole volume of patients. So how far have we come in this change of mindset?
Namaste to all, and at the outset, Hema, this is a wonderful initiative of the certification course. And as Dr. Anil Kapoor rightly said, I think we have to think of women's health as a complete women's health initiative rather than just a GDM screening initiative initially. Because as you said, the intergenerational transition of diabetes has to be stopped, and it can be stopped only in the womb. And then now coming to the selective versus the universal, as Dr. Muralidhar Pai said, we are for universal screening of GDM in our population because we know the high endemicity of diabetes mellitus we are seeing today, especially in our perimenopausal women. Probably if all these women, when they were in the womb, were screened, their mothers were screened for GDM, we would not be seeing them in diabetic clinics today with all the associated morbidity. And though there is some sort of a hesitancy, I would say more with the practitioners rather than the patients. all pregnant women are open to whatever advice their obstetrician gives them. And the moment you tell them that GDM screening, universal screening is a simple one-step DIPSI 75 grams glucose challenge test. She walks in at any stage of any time of the day, full stomach, empty stomach, doesn't matter. She gets a simple test. And the moment you tell her that by preventing hyperglycemia in yourself, your child is going to be prevented from fetal programming of maybe diabetes in future, they have no hesitation in getting the test done.
Right.
And I think it's very feasible in all our setups. One, the hesitancy we are seeing is more from the practitioners. I think that thought block in our practitioners has to go. And this initiative and certification course you have taken, I think will definitely go a long way in bringing this. And a sincere request to all our practitioners, please do not miss this one-step test, the most valuable test you could give. Please go in for universal screening of gestational diabetes mellitus.
Yeah, thank you,
No
Bharti.
excuses
Bharti, special congratulations to you because the Sahyadri Hospital team has scored 16 on 16 in the
Thank you.
recently
Thank
assessed
you.
Manyata assessment.
Yes.
And what is your message to the frontline healthcare providers? Because I'm sure now every staff nurse in your own setting will be able to counsel the patient properly about how to go about the test. So what's your message to the frontliners?
So I keep telling them that please do not take the Manyata just for the sake of the assessment. Please follow whatever standards have been given, the 16 standards in Manyata in the day-to-day practice. And I think if we push them, they definitely will counsel not only about GDM, about anemia, as well as the proper antenatal care. So this is my message. Please follow what we have taught you.
Yeah, sure. Thanks, Bharti. Now we'll swing to
Thank
Kasturi
you.
and after that to Dr. Usha Sriram. So Kasturi, the changing trends on testing in your own institute. Bharti just said, even in your institute, the patients may be most willing, but are the providers willing? So have you changed the strategy in your own setting? Because I do remember a couple of years back when I had come, it was quite a battle to convince everybody. So how is the situation now?
Yeah, now it has changed a lot. In the past, what we used to do is like only selective screening, only people with macrosomia, past history of BOH or IUD or elderly gravida, only selective screening was done. But now we do universal screening. Thanks to you, you started that initiative in our hospital. So now we do universal screening for all the patients who walk into our hospital. One is that is the biggest change. Second is, when we used to do in the past the test, I remember when we were students, what we used to take glycosuria as this test, those days, Benedict's test we used to do and glycosuria. Then came the blood sugar. Blood sugar also we used to call them, one is fasting and postprandial. And so patient they had to come from far off village, tribal, rural, it was very difficult for them. And for selective patients, we used to do GTT. Imagine for GTT, that patient has to come from a far off place fasting. Then after 1 hour, 2 hours, 3 hours. So, and previously also we used to tell her not to take sweets for previous 2-3 days. So for this one test, she had to prepare from 2-3 days as if it is a pre-operative preparation like that, and then come to the hospital and spend so much of time in the hospital, like fasting 1 sample, again 3 samples, and she has to take glucose. So whole day used to go in just one testing for the diabetes.
Right.
This for selective screening we used to do. But now, with this one-step DIPSI test, which you have introduced, which you made everybody sensitized, it's a big change. Now we are able to screen every patient who walks into our OPD, and irrespective of their meal, as soon as they come into this thing, we give them that 75 gram glucose, and we make them wait for 2 hours. In that 2 hours, they get their BP checked and other investigation, ultrasound, whatever. And after 2 hours, we do the test, and on spot we give the results. So it's made a huge change for the patients. It's just like walk in and then get it done and detect diabetes. It's so very changed. And one more thing changes. In the past, we used to call them in second trimester for screening. Second and third trimester. But now, the first visit only we screen. So first visit, again in the second trimester and then the third trimester. So we don't miss any of the patients who are going to be diabetes. So screening and detection is almost 100%. And you started that DIPSI screening in our hospital. We sensitized all our staff. I remember first time we attended was in Chennai. You had called me So Chennai, for that hotel. So there where I got sensitized, I came and sensitized our staff and they started doing it. But a full 100% it was possible when you started, I think in 2018-19, we started that project in our hospital. Everybody got sensitized. Now everybody does this test.
Excellent.
Step, universal screening and in the first visit. It's
Excellent.
Very change in our hospital.
So Kasturi is at the top of the change makers list. Congratulations and thank you, Kasturi, because it's not easy in huge public settings. What is your one message to many other public hospitals in the state of Karnataka who are still having a mindset, no, we can't do this test universal. No, we can't. Even in last Kasoga, that is our state conference, they said, madam, how do you say that maybe in small private practice you'll do, but in public it is not possible. So what is your message to them?
No, if we sensitize all our staff members, all the healthcare workers, everybody, tell them the importance, tell them that it is patient-friendly, doctor-friendly, and it is going to make a huge change for the patient, both for perinatal and maternal outcome and her long-term health also. If we sensitize everybody, so I tell everybody, please do universal screening, do the screening in their first visit and in the second trimester and third trimester, and this one-step method. So it's very easy. You can give them the results there, you can advise them, then you can advise the further diet, exercises, everything to the patient. So please make it universal screening.
Again, my famous quote, where there is a will, there is a way, otherwise there are only excuses. Yeah, thank you, Kasturi, for being so strongly positive. Now I swing to Usha, after that Charmila and Jayam. Usha, again, the question is, see, we may be thinking that public health settings is a huge challenge, but I know, and you know also, that even within the private settings, we have huge challenges. So your experience with the challenges both in public private settings, within the private settings itself, because I'm very sure you would have got n number of referrals which you would have thought that, why haven't they tested before? Why did they not send it to me before? And things like that. Are these kind of situations still prevalent? And do these questions still haunt you, because you are one of the leaders for women and NCDs in the entire country, who has gone really out of the way to sensitize not only our community of doctors, but also the girls and women, and reaching the last mile with your Divas and the Didi program and some very wonderful initiatives with many other stakeholders, which is again a rarity in itself, because we have to break the silos and handhold with everybody to propagate the serious intent of what we have embarked on. So Usha, all yours.
Thank you, Hema. And coming from you, that is really high praise. Thank you so much, because you are, what can I say, the beacon of all of these things. Thank you so much. I think I sent you an email yesterday. I don't know if you got a chance to see it, because this frustration, what you talked about, that how is this happening in 2022? I sent you an email with the blood test results of a patient who had emailed me yesterday saying that I underwent this test. She's my, and what should I do? And guess what test that has been done? And this is a well-known OBGYN and a very good one too. So somebody in her team, has, obviously is doing. They have done a 100-gram, 3-hour test. But when they're interpreting it, part of it as IAD-PSG, part of it as DIPSI, looking at the 2-hour value as 140, the fasting as 92, and a 3 hours, 100-gram test. So the most important thing I feel is we all need to come to the same page. And only then, whether we will know the true, let's say, incidence of a condition, we will have what we call message discipline. The message that goes out, there will be a discipline in that in terms of what we are going to tell our patient, because this is so confusing. So I think, is it going to be through CMEs, Is it going to be through, some other initiative, but it needs to happen, or through FOXY or DIPSI, the organizations, associations need to really take this in a war footing, because not only in just screening, it's also in, of course, in diagnosis. And then comes the actual, whether it's medical nutrition therapy or prescribing recommended weight gain, or talking about what medications to use, when do you start metformin, when you don't use it, how many weeks, and all of those things. Everything is all over the place.
Yes.
So this all over the place needs to come to one place. And that, I think, is the big challenge. And to just follow the thread of the earlier discussions, and I sent you that also this week, if we have some mantra like test all,
test
early,
all,
test again, test correctly, and test again in the 4th trimester or postpartum. If we keep, putting this, testing guidelines into everyone, whether it's private or public, I think it will go a long way. But more importantly, we can't do this mishmash of taking DIPSI, IAD, PSG, old WHO, new WHO, Carpenter, Kustan, or even going backwards, taking all of that and putting it in a pot and stirring it. That's not good.
You know what, actually the DIPSI test has been so comfortable to the minds of the obstetricians, because we said, okay, this is simple to do. One test, one value to remember. Just let's get on
These
this.
are obstetricians, Emma.
Yeah. No, but that has been our comfort level with which we have been able to convince thousands of obstetricians across the country. Of course, we've not reached all the 40,000, but whomever we have reached are, quite
very comfortable. And I think that's what we should do. And if it is the national guideline, then obviously then we should all toe the line and stick with that. And then we'll be able to get uniform data.
Yeah. And Usha, but like how the follow-up question is your message to the families who have these girls and women within the family who need to be counseled about their lifestyle.
This is not your grandmother's pregnancy. This is not your mother's pregnancy. This is a very different, the health of girls today is different. They are starting out, the landscape is different. They're starting out with different kind of handicaps is one thing. And the health system has improved so much that women are older, they're, possibly better educated, marrying later, and they can have institution care, they have better health care. So nothing is the same as before, except the pregnancy itself. So we will definitely, and the women are starting out heavier, less healthier, more stressed. So many complications are there, more pre-diabetes. So they definitely need to be on, follow the doctor's advice and not the old wives' tale.
Thank you. This is a very important message indeed. Now on to Charmila. How does the DIPSI test translate into practice in a small town? I would feel, with my reflections, both the patients and the doctors fall in line with the recommendations in smaller places more easily than acting too smart as in the metros. That is really what I have found. So what has been your experience and your thought process, Charmila?
Thank you so much, ma'am, for inviting for such a great program. And as Dr. Kasturi ma'am said, we have all been exposed to your sensitization for almost 15 years. And we have been following that for a long period of time. My city, we actually conduct camps for rural health, rural women also, because I'm attached to an organization which has got self-help group women, lots of them, like 20,000 something. They conduct camps, and you'll be surprised to see almost a prevalence of 30 to 40% of undiagnosed diabetes, even in rural women. And my setup, we do a don't do a selective screening, we do a universal screening. We do the single step DIPSI procedure, and we do it in the fasting and non-fasting. And you found out that the prevalence rate is more than 30%. It's not less. So by doing this type of testing, we are not missing out on women who need those lifestyle changes. Like we are not jumping into medications at once. We see those women on the borderline. Most of them are borderline because I think there is something percolated into the community and lifestyle has changed a little bit, but borderlines are more. And when we advocate those lifestyle changes, it has caused a great impact in the mother as well as the baby. We see those short-term benefits also. And I hope we have got a data collection of these women, and we hope to see the good benefits in the babies also when they collect or when they do the proper method of treating themselves, because we advocate a self-monitoring. We keep on counseling about how to control themselves rather than coming to us for checking their sugars, and anything goes wrong, we ask them to call over the phone and talk to us, so that there's no problem in compliance, because the compliance is the biggest drawback when we counsel women with those borderlines, because they do not have any symptoms. So it's very difficult to tell them what's going to go wrong with the mother and the baby. So, but when you tell it correctly and ask them to do it at home, they do it quite well. And you've seen a great benefit. And I hope to provide data to you probably in the next 5 years regarding these women of how the benefits is translated into practice. And the other thing is in Manyata, when we're doing the assessments, we found we used to teach every paramedical person about DIPSI, and we taught them quite well. But when it translates to assessment, we find in the metro cities, there is a bias towards doing these tests. And I may be biased, but I feel that practitioner who's trained abroad has got that reluctance compared to one who's trained in India. And I tell them it is not the Royal College or American College you need to follow, because it's an Indian population. We are totally different from the rest of the population, and that they need to follow this. And we have got complaints once we talk to them personally, but otherwise I find there is a block there in metro cities compared to the smaller cities. Practitioners in smaller cities are quite compliant, and they want to follow what is right.
So it's like the truth be told about what is the ground reality. When you said Royal College and American College, we have somebody from the Indian College, the immediate past chairman, Dr. Uday Thanawala, who so kindly joined us, because Uday always says, I'm always there for you. Hey, man, here he is. Thank you, Uday. They're just going around the kind of thought process which I had discussed with Uday in the recent past, just about 3-4 days ago, that I need the voices of all our champions and the leaders on each of these issues related to hyperglycemia and pregnancy, and also a message to the lay people, so that at the end of this program, when we get the link, we are going to make the 2-minute video snippets for circulation, because saying it once is not enough, and we need to keep on hammering this again and again. And Diamonds Are Forever, the series which Uday has created, maybe that gave me the thought process that, okay, we also do something which creates a constant video buzz. So thanks, Uday, for joining us once again. So as I said, Charmila, just one small question. You said in the villages there are your outreach camps, but do you test only the pregnant women, or you'll test the entire population, which means that the pre-pregnancy and also the 35 plus women who are there, do they also have the sugar testing? If so, is there any hesitancy? They're saying, oh, nothing is wrong, I have no symptoms, why should I come to your camp and get myself tested? What is the thought process in the minds?
In Tamil Nadu, we are not supposed to test pregnant women in camps, madam. So we don't. Okay. So we do for the age group of 25 to 45, because those are the women who are those in that self-help groups actually.
So we found importantly, so do they hesitate to come and subject themselves?
No. I heard somebody else talk also. Women are quite receptive. I think Bharati said that. Very receptive. It's a practitioner who has to change the mindset and think the patient is not going to accept. When you talk to them correctly and tell them about the transmission to the baby which is going to happen, they will be very, very receptive to doing the test, because when it comes to the baby, Indian women, I think, will leave everything for the baby's sake. So once you tell them you have to manage your diet and exercise for your baby's sake, they do it quite comfortably without any problem.
Excellent. So I think this is a point very, very well taken, because the entire village, the girls and women in that age group are tested, I think it will go a long way in tapping the undiagnosed cases for an early care. This brings me to Jayam Kannan. who is our evergreen champion. And I'm so proud to be, having her shoulder to lean on for so many of the events in which I need her help. And she's always the frontliner for me. So towards reaching the unreachable in the antenatal scenario, how far have we come with the DIPSI test? Because you are probably one of those who have assessed the maximum number of Manyata centers, and you would have recognized that when they started, they had no clue about this testing for hyperglycemia universally, nor doing the single step test. But when you actually assess them, they were all converts. So what has been your experience? And next I will come to Sushila Rani and Bhavatarni. Before that, we will again play a small video clip of Sheshaya sir. Jayam.
Yeah. Thanks to Dr. Sheshaya and Hema. I remember Sheshaya saying a couple of decades ago, 2 decades ago, I saw 2 obstetricians, young obstetricians, Sujata and Hema, standing on the side in a diabetes conference. And from that day onwards, Hema has never looked back on taking interest in diabetes and pregnancy. I'm very impressed with Anil Kapoor's words of 7 janmas and the doshams. And this is very true, especially for Sarba dosham. If you have this thing, they killed Naga Sarbam, this thing, king of the Sarbam, this thing curse falls on you for the next 7 generations. The same way, there should be some relation with the genetics, motive on this diabetes also. And Anil coming from an area of Brazil, which is 5.6 to 6% of diabetes in pregnancy. And we are in second in the world with 14.5 in diabetes in pregnancy. Karnataka, Tamil Nadu nearing more than 20% of diabetes coming into pregnancy. India need to check nearly 6 to 8 million diabetic women for diabetes in pregnancy. Are we able to reach all of them is the question. When after you gave the talk, I went into the primary health center, nurses, VHN, and looked at them. Government of India has said, give them 75 grams glucose and do the test. Are you doing it? To my surprise, I found no is the answer. Only when they just do the glucose test by the meter and they find the blood sugar is above 130, 140, they, as the pregnant woman, come to the primary health center, and then after that, they do the 75 grams glucose and 2 hours postprandial. This is one area where, in spite of our National Family Health Survey 4 boasting itself, doubling the antenatal visit, increasing the number of antenatal visits in the rural areas, still we are, in spite of our words, we are still lacking in this essential milestone. But of course, I won't be sorry to say that at least they have been tuned to do at least one glucose test. And from that, pick up those people who a random blood sugar is a little high and take them to the hospital for doing a DIPSI test. By this, there has been a recent paper which you also would have seen in August 2022 in the Journal of Family of Clinical Medicine, that DIPSI is able to find out only 60%, 40% is missing. At least we are able to get 60%. Not, we are missing only 40. We are not missing 100%. In my practice in the last half a century, the number of stillbirths which I used to see earlier has remarkably come down after I insisted on doing the DIPSI at the first visit itself. That is a great change. And reaching the unreachable, yes, we have done to about 40%, but still we are yet to reach the rest of the 60% in the rural areas.
So, Jayam, what is your message to the rural women or women at large and the doctors, the general practitioners, family physicians, everybody practicing over there, whomever they can access, they will go to them. So, mass sensitization of them, test everybody and challenge them with sugar and test it. Can we give such a message to them so that they will start doing better than what they are? Or how do you plan to escalate this 40% to 100%?
100%. Once they find one complication in their pregnant women and the patient starts accusing with their fingers, indexing them, you did not test me for sugar. You made my baby to be lost. I developed hypertension because you did not find out that I am also a diabetic. When this indexing is coming up, definitely doctors will accept the challenge. And we have, in the next 2 decades, as Sheshaya has done in last 30 years, in the next 20, 30 years, if Hema continues to do this, probably this will be taken up in the rural areas of everywhere in India.
Thank you. Thank you. We always live with optimism and hope, and wherever possible, in whatever it takes, with all of you as champions, we are certainly.
Madam, that's too far. That's too far off.
20, 30 years sooner than rather than later.
Off.
उससे थोड़ा margin जास्त दिया है, but we will do it
in our 50s. Sheshaya is in his 80s. So that is why I said next to 30 years.
Okay. Now it's time to hear from Dr. Sheshaya once again. Chitrakala, can you play the midsection clipping, please? Yeah.
How to, we know, all of us know the number of treatments are available to diabetes. But somehow it occurred to me this month, the month of April, we should prevent.
Chitrakala, is there an issue with that? Should I go on with the questions? Okay, it stopped at the right point because the next burning question to Sushila Rani, which I have to ask, how do you deal with people agreeing to disagree with a single step test? We all know everybody has vouched for the fact that, and you and me have dealt with jointly with many such people that also we are aware of. So how do we get them round to explain to them the ground realities in our country? And that this is, like Jayam said, at least you're picking up 60%. At least you're not missing the whole lot of them. So how do you convince them to become the converts?
It is not a question of so much convincing, but it's a question of getting themselves to commit to the single step test. One thing that I ask is, quite often it is the physicians who come up and say, no, we want to follow the IADPSG. I said, let the woman come fasting and then, we will do the IADPSG. I said, fine. For IADPSG, the woman has to come fasting. What time do you think your pregnant woman can come fasting? If she has got up at 6 o'clock in the morning and comes to your clinic at 11 o'clock in the fasting, do you think the fasting value is still valid? Do you think the fasting value is still valid? Absolutely no. It cannot be valid. She has put in so much of physical activity. A woman, especially in the Indian household, is extremely busy in the mornings. And by the time she finishes all her work and reaches in a fasting state, and that to a pregnant woman, that fasting value cannot be valid at all. So in the very beginning itself, this kind of a testing with an IADPST value is not practical to our community. If it is possible for her to come at 8 o'clock in the morning for the test as soon as she gets up, then maybe there is some validity to the test. Now, when I ask this question, most of them come around, it is not possible. Yes, there can be vary. And then somehow I get them to agree to get the DIPSI test done. So this is one way. And then if they got continuously disagreeing to what I say, I said, okay, fine. At least you get the IADPST done. It is better to get some test done that is valid than not to test our pregnant women at all. So this is what I would say. They'll say, no, our women will come. They'll come in the morning. They'll come any number of times that we ask them to. I said, okay, fine. That is only a small set of women that you're talking about. You need to look at the larger perspective, and then that may not be practical. And over a period of time, Hema, I've seen that most of them have got converted to the single step test. Yes, there are still a few who stick on and say, no, our test is better. This is not okay. But most of them have been convinced that single step is better. And then another point that I want to add is, in in our practice, where 1 in 4 pregnant women has got diabetes, gestational or pre-gestational. I would
Right.
say treat every pregnant woman who walks into a clinic as diabetic unless their test proves otherwise.
Right.
So what
Right.
do I mean? The moment she books, you get a OGTT done. And then the first question that they ask once the pregnancy test comes positive is, doctor, what should I eat? What should I not do? And then, I pull out, I have a PowerPoint itself. And then I pull out, I'll say, this is the kind of food that you need to eat. Just because you're pregnant, you cannot indulge. So at the very beginning, we need to prevent her from getting converted into a gestational diabetic. That is one thing. Another thing is, I talk to them about the recommended weight gain at the very booking, because we know the more weight gain that they have during pregnancy, the more the chances that they can become diabetic. So I talk to them about recommended weight gain. I talk to them about MNT, even though they have normal sugars, because that works in prevention of gestational diabetes, I feel.
Right. So this is a proactive preventionary precaution as a general measure that if you would take, it would go a long way in,
Yes.
in the pathway of the lifestyle change that you have already instilled in her mind, so that when you actually do the tests and there is a need to, be more disciplined than what you've already told them, then it becomes even a step easier. So, Sushila, your message to the postgraduates, because you are having the greatest number of years of experience in running the postgraduate course. At every course, have you found the confusion still persisting, and every time you have to kind of clean up and sort out? Or what is your message to the postgraduate? After that, before going to Bhavtarni, I'll just go to Uday because he wants to respond to something that Sushi said. Yeah, Sushi.
Wonderful, wonderful question. In the earlier years, it is not the postgraduates who are confused. It's the faculty who were confused. So I used to take a lot of time in trying to convince the faculty, because if the faculty are convinced, then the postgraduates will automatically get convinced. So it took a couple of years for us to choose the kind of faculty who would be convinced and who would get the proper message across. And now in our postgraduate forum, there is no question of anything else other than the single steps test. So it has, all over South India, this is what we see, that wherever postgraduate teaching happens, we talk only about the single step test.
Excellent. Thank you, Sushila. Uday, I think it was, you have to unmute, Uday. Thank you for joining again.
Yeah, thank you so much. I was actually, I've been listening to the full thing. I listened to Anil Kapoor and everyone. And coming to the very important part of screening, first thing is that when we're talking about the test itself, it is definitely the DIPSI test. And when you're asking questions to Charmila, talking about RCOG and all, the simple thing was, what happened to these countries when COVID struck? They were nowhere. They were saying, oh, do HbA1c, do only fasting. And they had no clue on what test to do, while we were, like status quo. Let's do this one step single test, which can be even the woman can test the glucometer in her own house. So she did not travel and give blood. That Sushila just told us about the IBGP test, people coming, sitting fasting for 3 hours. In COVID times, nobody wanted to do it. Wherever it is available also, nobody wanted to do it. So they were nowhere. So I think that is the importance of DIPSI test. And I think the other countries, Canadian guidelines and all those guidelines who were at a loss at that time, they should be looking at this DIPSI test and taking it up, because it is something so effective, so easy to do, and something which is very, very doable even in large populations like ours. And especially when you talk about postnatal follow-up, who it's very difficult for a woman to, at 6 months or at 1 year to leave the child and come and do a test here. So even if it's a point of care system where you're using a glucometer, we have to tell them, and that is one of the things what Anil Kapoor suggested about that bindi on the postnatal card is excellent. But unless we keep on hammering them at every antenatal visit that, okay, you have been discovered to be a GDM, you have to control it by diet and exercise. And if you want to ward off diabetes in future, it is going to be a lifestyle change for you. And then you have to tell them that do this test at this particular intervals, even after you deliver. So until we push it in the antenatal period to them, that postnatal follow-up may not happen at all. It happens very little even when we do it. In our private practice, we are hammering them, do it. Still very few turn out. But this is one thing which we have to do at all levels also. And one more small point, if I may, that when you're talking about women's wellness, we are gynecologists, we are dealing with such a large population of PCOS girls and obese girls. So preconceptionally, these are the girls who need to be told that, you're at the risk of becoming a diabetic. Please take care. Please improve your lifestyle. Get into the proper BMI, and that will sort of ward off these diseases in the future.
That question I'm going to ultimately hammer to Sampath Kumari adolescent. from Jayam, the adolescent baton has been passed on to Sampath Kumari. Now she'll have to, as an organizational leader and the vice president of Foxy, also she'll have to respond to that. Just hold on, Sampath. And Uday, I just want you to quickly, briefly reflect upon, the way we both did the ICOG first study. It was just, so mind-boggling. Just take us through that horrendous journey.
Yes, so it was Hema's idea when we were in ICOG that let's do at least a knowledge, attitude, and practice study, where we realized that people are doing whatever they want, including simple urine sugar, or even, and most commonly test done was random blood sugar, because nobody believed in giving the patient any instructions, nobody at the time. So that was what was being done and we've come a long way since then, because after that, the whole the idea of testing the American guidelines which were followed at that time. I remember Hema had taken vans into the rural Karnataka and asked the women to come to do that 2-step test, and once 50 grams of glucose, discovered to be diabetic, called back again. The recall rate is poor. Even when the women came back after 1 or 2 samples, they ran away. That how much blood are you sucking, sort of things. So all these were the practical problems which made us realize that no, these tests which are propagated by either the American guidelines or the foreign guidelines will not apply to us. We need something indigenous. And thanks to Dr. Sheshaya at that time, I think Sujata Mishra, Hema, and Sheshaya, and we all discovered that this DIPSI test, which Dr. Sheshaya had done a study there, that non-fasting or fasting does not make a difference if you do a 2-hour glucose challenge and if it is above 140. So that DIPSI test was the one which we clinged on to. We have done so many validation studies. We have realized it is more or less the pickup rate is similar, more if not less, and it is something which should be done throughout our country as a uniformity. Because like Sushila said, that IIDGP test also is not easy to do even in private practice. So I have switched over to DIPSI test for the last 10, 15 years or whatever, and everybody gets screened for this glucose challenge, irrespective of whatever their BMI is, etc. And I think it's something which is so valuable that we should be now telling the world to do the DIPSI test, because now COVID has taught us a very, very good lesson. And I think Usha has a fantastic paper, The Sweet Spot, what she's got. And it's a lovely read, what Usha has got. And it really focuses on the DIPSI test so beautifully.
Yeah, thanks, Uday. And I think that as organization leaders, as the chairman of ICOG, today I've specially invited Dr. Kiran Pandey, who is the chairman of the medical education committee of Foxy. And I've already pitched the idea. You were hugely successful in bringing out the weekend courses for the skill transfers, Uday. And I want you to support Kiran as well in nationwide launch of the e-certification course on the hyperglycemia in pregnancy and other high-risk issues as we go by, so that in a passive manner, at their own leisure, they should be able to study the contents as well as take the exit exam and be empowered to do more. I will ask Bhavatarni and then next to Kiran to also respond to the idea. Okay. Bhavatarni, the question to you is, I know of how much, little bit I struggle, but a lot you struggle to go to the ministry, approach them, get them to declare 10th March as the GDM Awareness Day. What was the, effort involved in that? And having declared that, okay, all of our champions have got together doing something special on that day. Do you think it has made a difference, and how much more we need to do? Bhavtarni? Because the whole buzz around here is let the women know. let them know, let them be sensitized to the fact that this is an issue. They have to come up for the test and they have to demand the test as if it were from the clinicians. About that, you're muted about that. Yeah.
Actually, on seeing the difficulties in the older procedure, what the government felt, it was very difficult to screen a huge number. If you see the rural side, that forms the backbone of our country, who have to be concentrated. With the older procedures, it was very difficult and confused whom to screen, how to screen, when to screen. All these problems were there with the rural people. I was going around throughout the Tamil Nadu, seeing to all these difficulties. After the introduction of the single step procedure, the government is much, much pleased because it's very easy, economical, and they were able to screen all the women. Because of this, they wanted to honor our founder, DIPSI president, in some way. But still, you were the one who are instrumental in predicting, saying Sir's name, his birthday, to be practiced as GDM Awareness Day. You only gave the first idea. After this, only the all started, along with Dr. Anil Kapoor. You both were so instrumental in insisting that government, of course, wanted to make some awareness among GDM women by considering this day GDM Awareness Day. And after that, it was very easy for us to go reach the government. Maybe me, myself, Dr. Purandare, Dr. Rajiv Chawla, Dr. Rajesh, we all went again and again and said about the advantages of this procedure, which is very much accepted and appreciated, especially in the lower socio-economic groups where they have been so far. They have been not done. They were not undergoing any test and facing all the consequences. And as Dr. J.M. Kannan said, after adopting the single step, it was so easy for the whole government side. I'm saying not about the 5 to 10% of persons who are not following our procedure. They are very much convinced and they were following and doing this in every universal. When they came to about the national guidelines that all has to be tested, and it's in the very first visit, that is in the first trimester with the single step. It was so easy. When I went after that, for some time also, they said, you do whatever want you do in GDM, but don't change our procedure of DIPSI. They are so much happy with the procedure. And so the government is also very much happy to honor our president by celebrating his birthday. And you know, in pregnancy, if you ask them to come again for the second visit, they are all coolies. They have to get permission from there where they work. And if you ask them to come again, if they just don't come the very next week or something, they choose their own days. Then what happens? The fetal handling starts and you may miss the diagnosis also. And if at all, if she happens to be a GDM on that visit, it will delay and it will increase the morbidity, like how our sir says now that once it has started, you cannot stop. What he says is to prevent. So it has to be caught in the very first visit. And being pregnant, they don't come alone. They are always accompanied by another person. So these lower socioeconomic ground reality, 2 wages of God. They don't want to lose their income in another day. So they may not turn up at all. As you said, there are many dropouts. So, and another thing, as Kasturi Madam said, it is not only this test we are doing in pregnancy. We have plenty of other tests to be done. And we cannot spend the whole day for doing this test, taking 3-4 procedures. And even if you have asked them to come again in fasting, the hypertonic solution, they are not able to tolerate that hypertonicity of the glucose solution. They vomit. All the efforts of putting them to asking them to come in fasting goes waste. All goes waste in many a times. Practically, this happens. So, as far as the government setup is concerned, where there is scarcity for everything, they always welcome, which is very simple, easy. At the same time, it should be very useful for the community, patient as a whole. So it's a very happy, they welcome all this, and it is very easy because I go around throughout Tamil Nadu, I find this They are very happy. And again, I want to say, rather than saying that we are 11% more prone to get diabetes, nowadays it's a single child. She gets married very late and further delays the child. And the age of occurrence of diabetes is coming down. So what I say, every pregnancy is precious.
Yes.
So we have to consider all these criteria. What we have given well ahead is very much useful and everybody accepts.
Yeah. And then not only that, the government has wholeheartedly accepted it, and those who are doing it have felt the ease of doing and also have discovered a lot many more cases in their own practice. And it's been an eye-opener to them. So many, years we didn't do, and we have probably missed some cases. So that is the change in the mindset and attitude. And I think the awareness day goes a long way. Like Father's Day, Mother's Day, it's a big buzz that is created. And that is what is also the need to reach the public onto a fact that the diabetes in pregnancy is real and it's big in our country. And so better wake up to this fact and do your best and help your doctor do their best. So that is how the Awareness Day sensitization has come about. So thank you so much, Bhavtarni. Not only that you've been instrumental in many things, but you are a constant pillar of support for Dr. Sheshaya, taking care of every of his travel needs. And only because of you, if Bhavtarni cannot travel, then Sir cannot travel. It's almost become like that. So thank you so very much, because
Thank you.
That is another extra mile that we have gone to support the stalwart in this field. Thank you so much. So
Gifted to have that, madam. I have that gift.
Yes. So Kiran Pandey and then Sampath Kumari, because we are coming to the organizational responsibilities. Before we go to MNT with Vidya Tobi and long-term care with Vijay, we will finish with Kiranji. After you announce your thoughts on, as a chairman of Medical Education Committee, whatever the knowledge and education is, it needs to be translated into practice. So what is your thought process of how to make this happen? And I have already made Uday commit his support to guide you for a lot of things, along with the whole bunch of us who are ever enthusiastic to do. And after you speak and some Sampath speaks, we will again relaunch the Karnataka chapter. We are piloting this e-certification course. Dr. Kasturi Dhonimat was not there when we just put the 10-second video, so we will replay that again. So Kiranji.
Thank you, Dr. Hema. First of all, for giving this opportunity, and congratulations for taking this wonderful initiative. Dr. Hema, what I've heard, I've been hearing since Dr. Anil Kapoor and everybody else, from Dr. Kasturi, Dr. I mean, lots of views have come, practical things points have come out. One point which I felt, one thing is that you were talking about postgraduates. See, as a medical education committee chairperson, I feel the postgraduates are those beginners. If we strike them at the right point, each and every one, then definitely they will adopt, because whatever we were taught in the postgraduate days, that stuck to your brain completely, and then you can always follow. It's actually, even though everything has been said, so much good percentage and so much good results, still, we know that many people still in various areas are still hesitant or not aware. 1 or 2% will come out who will ask after the meeting, Madam, isme kya karna hai, ye kaise karte hain, kya difficulties hain. Even certain difficulties I've seen with the lab people also have talked, like they will give it, and then between those 2 hours, they will allow the person to move around and go to the other places. So that part, the finer things are lost. So the postgraduates are we target them really all over India or even outside. That can make the difference. Of course, it will take some time, but will take a great difference. So this idea of launching the postgraduate courses, e-courses, is definitely going to add up a lot of benefit. And as Dr. Uday said, one more point, it was very wonderful of him talking that the DIPSI test has made a mark on the in the chapter of gynecology and ops. But still we need to take it now to the wider platform, even to the world we are, because we are able to prove it. We have done it wonderfully. The results have been shown perfect. So now definitely there is this is the right time to take it to the world platform. So that's also a very good idea. And thirdly, I would just like to say one more point, because I have been just added, maybe the time is short. Dr. Sampath Kumari I'm lucky to have her as a vice president. So this will further help us together if we are able to take it, because she will also be we have also worked during the adolescent committee, and we'll also work now. So as a medical education committee chairperson, I would in fact request and honest ask each and everyone to come with further posts and the initiative vigor to take this initiative forward. Thank you, Dr. Hema.
Yeah, excellent. Thank you, Kiranji, for joining, because yesterday we were together at Kanpur and we brainstormed on this idea, and she was kind enough to join us today, because we want this larger, wider, deeper, not only pan-India, but also in the CEFOC countries and African countries, and through PIGO, many other low-middle income countries. And they are very, very keen, but they need to have their competence and confidence a little bit tuned in. So with these courses, I'm sure that it will strengthen and it will give us the role model edge. You know, that we've done it, why can't you, kind of a thing. Thank you, Kiranji. For Sampath Kumari, I had a loaded question. What activities through Foxy in the past, present, and future? Especially, you know, when you've done the Manyata, also you have recognized that little bit hand-holding of the staff, they will grasp it immediately and make sure that every patient in their setting is, you know, going to go through this. I know that Helping Mothers Survive program, which the champions from Tamil Nadu took it up, they never stopped, you know, because it was so crucial. So what is your plan for the continuum of percolating the Government of India, Foxy and FIGO guidelines as far as this is concerned? And the second part of the question is your message to the youth of the country, the adolescents who need to inculcate a change in lifestyle, which is a huge part of the preventionary measure, which Sushila said should anyway do it from the first visit itself, but even prior to that, what is your thought process? Sampath.
Thank you, Madam. First of all, I thank you for the wonderful opportunity. And when you tell about the adolescents, first I should thank Dr. Jayam Kannan. She is the one who introduced me to the adolescent and to Foxy. See, as you told, with Jayam Kannan, Madam, we have done many programs of HMS. That is, every corporation, hospital and medical colleges we have done. From that time itself, we are talking about this DIPSI in the schools. And next, the Manyata. I think almost in Tamil Nadu, all nursing homes have been certified with Manyata program. In the TNFOG also, I am motivating the people.
Yes.
As far as Tamil Nadu is concerned, I think DIPSI test is done everywhere, whether it is a government hospital or a private hospital. But as Charmila told, there is some Royal Colleges going on. That they have to change. That is the only point. I don't know, because 2 times means, as Bhavadani was telling, patient cannot come again. It's the first thing, if you are going to give the glucose, already they will be having the nauseating sensation. With this, again, they will go for nauseating. As Kasturi told, in this test, they can give the single test. They can give take the glucose and do the other test, the simple test, the BP, weight, and everything. And they can get the result the same day also. So they can do even in the home. Nowadays, there is in the private sector, there are stations available. We can tell the patient, you take it by 4 o'clock and go to the lab by 6 o'clock and get the report and come to the clinic by 8 o'clock. Over. That's all, everything. So the single test, I think it is well done in South. It has to go to North, East, and West. That is the main aim. Now, the South already people are doing. Then the adolescent, coming to the adolescent. These girls, whenever now when they miss the periods, all the mother-in-law, sister-in-law will be anxious whether you got the bleeding or whether you got it, we want to do the UPT. So we have to tell them whenever they do the UPT and if it is positive, in the next hand they should do the GCT, DIPSI test. So UPT is positive means again GCT is negative. In this way, if you are going to do that, we can avoid the future PCOS and the future GDM. So from this GDM, the adolescents PCOS and the adolescents going for GDM and obesity, macrosomia, everything can be treated. Already with the Uday sir help, I did this adolescent certificate course. Again, now we are doing in the Lakshmi Madam's period also in the July. And as Kiran Pandey told, we are doing a hyperglycemia in pregnancy with Dr. Hema Devakar.
Excellent.
Madam. So with this 2 certificate course already they are given to ICOD. One is HAP and another is HAP. So unless you do the exercise and the lifestyle modification to the adolescents, you cannot reduce the incidence of GDM.
So Sampath Kumari is going to take us all the way to Andaman to do this adolescent program, because the schoolgirls there also are getting sensitized. When we are going there, why not in and around our own homes, says Sampath Kumari. So thank you so much. As Kiran said, we are lucky to have you as a vice president, because very supportive, very proactive, and you know what these ideas mean to be translated into action. In fact, that is the title of today's session, Ideas into Action, because all that we have reflected upon already got into the action zone, but all of us recognize that it has to really escalate as much as possible. We will have Chitrakala play the launch once again. Yes, please. Yeah, so it was just one quick meeting with Dr. Kasturi Donimat, who is the president of the Karnataka state chapter, and Dr. Vidya Topi, who is the president-elect, Dr. Bharti Rajshekar, who is the secretary, and the other office bearers, inclusive of Murlidhar, who is the chairman. In an instant, they said, yes, this is what we need to do, and let's do it. Let's get moving with it. So 14th November is a symbolic launch, but we have a lot of back-end work to do, and we want to learn our lessons from this small geography of Karnataka, recruiting primarily, as Kiran said, the postgraduates, and we'll tweak the modules a little bit, get that into a proper shape, and expand this to TNFOG, expand this through medical education committee of FOXY, handhold with ICOG Lakshmi Shikande, and of course in the prime position of vice president Dr. Sampath Kumari. So we have to get this moving, according to me, forever and forever, because we need, it's a long journey. Now that everybody has told, if this turns into a reality, if everybody does universal testing and every nook and corner this test is being done, what will happen? Many more millions of hyperglycemia will come into the picture. Then it falls on Vidya and Vijay to tell us how this medical nutritional therapy, which is a complex thing, and Vijay, how you will get them back for a retest after their delivery, because once they're take home baby, take home mother, everything okay, then they'll do tata bye-bye and go. That is the scenario. After which I'm going to come to Anjalakshi, who's been patiently waiting, because she is the main torch bearer. She is the one who has been associated with Dr. Sheshaya for decades together. And as if there is no stopping, she is now in the forefront of the new idea of the research work that we are going to embark on the primordial prevention. And I will question her around these areas so that all of us know what is the next best thing that this group is going to do. So Vidya, medical nutrition therapy, easily said. But how easy?
Yes, Emma, I heartily congratulate you as a DIPSI president and taking over this certificate course across Karnataka and maybe at the national level. And really thank you for inviting me for this important topic. And you all know how much interest I have in nutrition part. And we all recognize that the nutritional counseling or physical activity are the primary goals in the management of gestational diabetes. But it is very, very difficult to give this practical nutrition education and counseling, because it is mainly the family we have to educate, and mainly we have to educate first the people who are treating, the doctors. They don't recall on any. I think I have just done a survey, small survey. They don't record the weight or height. They don't record the BMI. And then the cultural, the behavioral pattern, and whatever the eating patterns, they differ. You know that in North Karnataka, the incidence of gestational diabetes, if we say, maybe because of their eating pattern, they are different. So we have to empower them to choose the right quantity and quality of the food. And then the follow-up is very, very important. I cannot have a good dietitian like Sheetal with me, but definitely I can have Hema's diabetic food plate for explaining. I congratulate you for that. Maybe Sheetal will throw more light on what to eat, what not to eat. And then when we become very rigid about the diet, it is very difficult them to follow, because there are a lot of cravings in the pregnant woman and they tend to eat more. So according to BMI, according to their cultural practices, and according to the availability of the food, we have to advise, and according to their status, we have to definitely advise. And this we have to teach. And maybe in your certificate course, I have a simple small place. Small, no, it should be a bigger one, because we say that medical nutrition therapy
is the mainstay.
For any of the treatment. The physical activity also should not be forgotten. Simple physical activity for these women are very, very important. So healthy eating habit after delivery, even postpartum, the weight gain, all these things are very important things. And I congratulate you for the diabetic plate. I have not got it, but I simply draw it and ask them to eat the complex carbohydrates. I teach them about the carbohydrate exchange and whatnot. So it is a long, if I go on talking on MNT, I think I will take more time. So I stop here and I will give the opportunity to EG again.
Thank you. Thank you, Vidya, because, the Food and Drug Committee of, FOXI made a tremendous mark during your time, because there were so many new issues that we got sensitized into, and the whole of SHIELD team is here. I had seen Mahadevan also join in the earlier part. Balaji is here, Senthil is here, Chitrakala, Stalin, Sahiti, and all of them. They will take this message forward with the plate, because they were waiting for an appropriate opportunity how to just percolate so that it just stands on the table of every single OBGYN. So easy to explain. So right from November 14th, the World Diabetes Day, to March 10th, the GDM Awareness Day, their journey with the plates will continue pan-India. I can promise it on their behalf, because they really mean to do their best to contribute in a very significant and an effective manner of what can be practically, properly utilized. So thanks again, Vidya. And we need more help from you, because FIGO, Think Nutrition First, that's the FIGO checklist which we have worked on in the Indian context. And every single clinician has to fill up that FIGO nutrition checklist, take a dietary recall, understand what this patient is already eating, try and see how they can manipulate to the best of the capacity with low carbs and high proteins and a little bit of fats and low glycemic index and all of that. It becomes then easy to have that as a starting point. So thank you, Vidya. Viji, how do you make your patients come back after they've happily gone taking home a healthy baby? Because we have noticed that pre-pregnancy, they'll not listen to us. Post-delivery, they're gone. Only in pregnancy, they are so serious. They very meticulously follow everything and anything that we say, and even more, to the extent of diet restriction and starvation. But post-delivery, you ask them to come at 6 weeks, 6 months, annually. how many of them actually come and what do you do? And what is your protocol?
Yeah, definitely. We would like 100% follow-up. It's beyond our, I won't say it is beyond our expectations. Definitely, it has to be there. As you correctly said, the testing which we do for screening during antenatal is easy. Nowadays, with a little more clarity of concepts and, of course, introducing the single step test. But at the same time, even the fasting sugars that they do, along with other evaluations, which is advised during thyroid and all those things, they also give us a clue. So it is still existent that not all the patients go through single test. But then, yes, something is detected even in the fasting or not detected, we follow it up with a DIPSI test, or even later with if some of them are positive and they go through the MNT or the insulin. And because ours is a multi-specialty hospital, the physician is also involved. And I think along with the obstetrician, it is very important that the physician or the diabetologist is also there, because these people need definitely the long-term care. And we cannot, though we know we don't segregate the systems or the specialities, and mostly they are under our cover, but at the same time, they definitely, somewhere they branch out and then they get lost for follow-up. And therefore, it is very important. I would suggest that postnatally, yes, when they come to us for the follow-up of either the cesarean scar or the episiotomy, and that is the time we keep talking about this and what they have gone through during pregnancy as a follow-up or difficulties in pregnancy or management. And, maybe we are scaring them, but then, yes, we have to tell them it should not repeat. In your next pregnancy, you have to be careful hereafter. Pre-pregnancy, try to achieve a planned pregnancy, especially if you have been through a diabetic state during pregnancy. You definitely need to plan your next pregnancy. Just like how we give them the contraceptive visit, we definitely stress on this as well. And most of them are able to do that. Of course, some are lost for follow-up. And something, because the sugars have been normal after delivery, they have been weaned off the insulin, they have been weaned off the oral antidiabetics or even anything, and they have a liberal nutrition after the delivery. And some at home, feed them with bunches of this because you are lactating and definitely you need more nutrition. All these people, we do give warning symptoms that once you are diagnosed as diabetic in pregnancy, you run a risk of being diabetic, continue to be in a diabetic state hereafter, and you have to be warned. And then the 6 weeks, 6 months follow-up, and definitely a prenatal before they embark on the next pregnancy. They are able to do it, but yes, we have to keep on hammering this on them. And the only thing is, we can ask them to come for some other excuse. Say when they are coming as a post-contraceptive, post-IUCD visits. See, these are the time again and again you check. I know in our hospital what happens if a neonat is going into an ICU or had some special consultation postnatally. They are branded as a high-risk babies and they keep seeing them. I think what we do is we manage so many risk pregnancies, but then, we don't get all that credit if all goes well. And then later on, we forget that they are branded into risk category. It's not to scare them, but then we have to be vigilant as well as they have to be vigilant that they carry the risk of running a hyperglycemia anytime in life hereafter. And I think that follow-up is very, very important. We need to put them in a little different bracket, not just because they have gone through a very smooth sailing during pregnancy. That is because they have been managed well. But then they do run that risk of getting into trouble in the next pregnancy, or even if they are not going to be pregnant again, for their any general effects and general life thereafter. So I think stressing on the nutrition, stressing on the diet pattern, watching the weight, especially the central obesity, they have to do that. And exercise is important. and then not just putting abdominal binders and trying to tuck in and then say, oh, I've gone down. No, that is a false this thing. They have to make it through the muscle exercises, cardiac exercises and all those things. Keep a watch and then keep reporting to us at some excuse, and here we definitely follow. Because I put something on them, on their case sheet or whatever computer thing, so that I know, yes, they had GDM or they were diabetic at some stage, and we need to really keep on pushing them into this. And
excellent.
All other, if we have been involving other specialities, then I think it is also their responsibility to contribute to this. Sometimes they just get diluted in that management.
True. And also simple advices like, continue to exclusively breastfeed at least for 2 years, and then, your weight will be lost and you'll have less chances for type 2. All of these have to be drilled in whenever the opportunity is there. And, is there any strategy of, calling that patient, making a list and calling the patient back if she has not come for follow-up after 1 year?
We can do, because luckily I'm in a private institution and we don't cater to a huge volume. So definitely, but even here, every 3 patients, every 4 patients, one is diabetic. So definitely, we do remember them, and especially if we had tough time during pregnancy, we can never forget them. But at the same time, definitely we can and we should definitely enlist them, and then we can, surely enough, we should be able to contact them and say, how are you? Did you check with your sugars? Why you didn't come? I think we need to do that outreach programs, because even today I find patients who come from abroad halfway in pregnancy care, and they come here for some reason, either intermittently for a checkup, or maybe they have shifted their delivery point or whatever. Some are not done sugars. I don't know. Abroad, they have no concept that basically they are Indians. Whether even otherwise, we need to do the sugars. But basically, with the Indian ethnicity, they would have done lots of chromosomal screening, lots of hereditary disorder screening, but simple sugars are not screened enough.
Absolutely agree with you.
Come here and we do the testing, they are hyperglycemic. So I think we need to tell them that no, just because you did not go through in your half of pregnancy this kind of a screening, you need to take care of it. And hereafter, whether you return to US or UK or anywhere, remember that you are basically, how we call nowadays Indian origin. So the same, they carry those genes. And I think you have to tell them, as everybody said, when you talk about the kid, you talk about the children, you talk about their problems, because you have not managed yourself well, then obviously that will give a big warning sign on them. So
these are exceedingly important and very real points, which every one of us needs to keep in mind. And thank you so much, Vijay, for being here first. You were the earliest one to join in, and then, I've kept you waiting so long. And still, after Bhavatarini's comment, I have to go to the Dr. Anjalakshi, who is behind us all since decades in IOG.
Thank you for this wonderful opportunity. And we are with you in everything you do. Thank you so much.
Madam, I just want to add one thing. As diabetologists, we are struggling too much in the past 30 years to bring them back after delivery. As our Dr. Anil Kapoor always used to say, we have to club with the pediatricians.
Yes.
Only the place where we can catch those women as pediatricians.
And also, Bhavatari, I think, as clinicians, when they come, they may be coming to us not necessarily as post-delivery, but any point of time, 38 years, 40 years, 42 years, for any damn thing, okay, for anything, then we have to go back to their obstetric history, and also anyway compulsorily, get onto a routine check of the sugars as well, because there's a good chance that the obstetrician may not have tested and the spotlight may not have been on her in the true sense. So we should not really...
I'm also thinking, Hema, just 1 second only.
Right.
Many of the practitioners, as I have seen a little bit around my place, are still doing random blood sugar. I don't know what is the meaning. I mean, you better do anyway, you are checking with one sugar. Why don't you do DIPSI? I don't know. Random blood sugar, urine sugars. I mean, we know very well that urine sugars have no meaning in pregnancy. And then still people are, I think we need to still make it a little more loud.
See, we, looking back, yes, where we were, we have come a long way. And it has taken fairly a reasonable length of time. But from here, if we all get together, we can move fast forward. You know, with all these post-graduation, sensitization, hammering the same thing every time through our organizations, and, you know, speaking repeatedly about this. That's why I said once is not enough, you know, because even today's program I had planned that, you know, it'll be a rapid fire. What is, you know, it's the same thing. What's more to tell? But when you really reflect, there is so much in it that is an unfinished agenda. So that is really appreciated.
Since Bhavadarini is there any problem with the fasting hyperglycemia?
Madam, as far as we have seen, we don't come across fasting hyperglycemia
already
at all.
In pregnancy, there is exaggerated hypoglycemia in the morning.
Yeah, very few who have a strong genetic family history background, they will only have fasting. Otherwise, majority, more than 95, they don't have fasting hyperglycemia.
Yeah, but you know, always as I used to speak to Shesha sir, that something is better than nothing. Let's get, doesn't matter if other people comment that this is little flawed and that is little this and all that. But at least if we don't even do this, as if we were continuing the same practices, what we used to do 12 years, 15 years back, seriously, we would have missed many more cases in the entire country. Few pockets of excellence may have done something, but that would have absolutely not been enough. As it is, there's a tsunami of NCDs. It should have escalated even more. So as a final part, fitting final, I want the 30 years of experience, because this whole program is titled, it all started from the South. You know, the IOG, the great institute, which stands as a testimony for what we have achieved in the space of diabetes in pregnancy today. Dr. Anjalakshi, the past president of DIPSI, was much a part of it. Not only that, she continues to work with the same passion, and the new thought that has come on the primordial prevention. She is the one who is, you know, intensely distributing the protocols to us, urging us to start work on more research with the fresh thoughts, etc. So, Anjalakshi, the floor is all yours. Finally, and I'm really sorry to keep you waiting.
No problem. No, I was listening to everything. Thank you very much, Dr. Hema. Good evening to everyone. First of all, I have to confess that I am very fortunate to be with Dr. Seshia.
Yeah.
Okay. So this, the culture of diabetes has gone into my blood. Okay. So in that way, I'm very fortunate. And I was listening to all the diagnosis, and I agree that you are the lady of great ideas. The tsunami, the DDM plate, the course, we remember, you have conducted, you have divided India into so many regions, and we conducted the programs, and about 10,000 obstetricians have been trained already. But this training process should go on, because new people are coming in. And now I also appreciate and congratulate for the e-certification course for the Karnataka. Not only in Karnataka, it can be taken to all the states of India.
Yes.
Our India now stands first in the diagnostic procedure, because now it has been accepted all over all the Asian countries and most of the European countries. It is the credit is to you and to Dr. Anil Kapoor, who have taken this from Tamil Nadu to India and then outside the India. Thank you so much for all those things. Now, actually, because I'm not going to talk about the diagnosis of this and all, now we have sensitized, we have empowered all physicians in Tamil Nadu, of course, all people from India, we have sensitized, and they all know that the DIPSI test has to be done to diagnose. As Dr. Anil Kapoor has beautifully said, a torchlight shown on that pregnant lady. So the DDM. So from that, we have to go on. Now our Pitamaha's next idea is, because in morning he told me, I have passed in the single test procedure. Now the next step is the primordial prevention. So I said, sir, I am there with you. Okay. So now he is undergoing the test. And definitely he will get passed through that. See, the idea is actually when sir has gone through the literature and all, it has been in the National Health study recently, they have said 110 milligram around 11 weeks. So it predicts GDM. So now we know how to diagnose, how to treat, and we have to follow up which we are deficient. So that we have to follow. The next step is we should not allow the lady to get a GDM. So how to do that? So that only, as after going through all the literature, it is said 110 milligram in the early weeks of pregnancy, it predicts the GDM. So let us prevent this GDM by bringing down the 110 milligram less than 110. But when to do the test, that's very important. It has to be done at 8 weeks of pregnancy, because around 10 to 11 weeks, the fetal insulin starts secreting, and that will have all its havocs on the baby as well as the mother. So before that occurs, we have to reduce the blood sugar to less than 110 milligram, which we can do it either by the medical nutrition therapy, exercise, or even with a pharmacotherapy. That is, a metformin has been found to be very safe even before pregnancy and throughout during pregnancy. So that drug has been recognized and approved also to be used in early pregnancy. So we can put a small dose of metformin, 250 milligram twice daily till the 12 weeks, so that the hyperinsulinemia of the fetus will not be there. And of course, we are going to start only at 8 weeks. So the organogenesis, most of the organs have been formed already by 8 weeks. So there will not be any effect affecting the organogenesis by the drug. So this is the, the idea. So this is the idea which sir wants all over India to be done, so that we have results from multiple centers, and we will be when it works out well. As we conceptualized, it comes out well, then India will be the first country to prevent the diabetes. That is the dream. The dream of sir is the one. India should become the first country to prevent, because all other people are talking about early detection and treating, which will prevent only the complications of diabetes. And every year, so many people are being added having diabetes. So it goes on like a tsunami, your word, like a tsunami, the incidence keeps on increasing. So if we want to put a stop to that, the person we have to look out is the pregnant lady, and we have to see her blood sugar. That is a simple 2-hour postprandial blood sugar. No, not even glucose. So do that and keep it below 110 milligram. Okay. I think, with this message, all our physicians, our diabetologists, our endocrinologists, all will follow this. And we have to, of course, because we are in the it is only a concept. So we have to prove on this. So we have to continuously do the diagnostic test of OGCT in the subsequent trimester. That is around 16 weeks, 24 weeks, and 32 weeks. Okay. So with this, my message is, all pregnant women should be screened, and the physician should know the pregnancy is diabetogenic, and it is a stress test for the diabetes to be picked up. So during pregnancy, every pregnant woman should be screened, and the stress goes on as pregnancy advances. So if negative in the early weeks, you repeat it in the subsequent visits and diagnose. So that put the torchlight on them and keep them under follow-up. It does not mean that they require the treatment. Only 10% of them, they require the pharmacotherapy to bring down the blood sugar. And one more important thing is, after diagnosing, monitor the blood sugar. Keep the blood sugar in the target, that is in the normal pregnant values. That is, the fasting should be less than 90. And postprandial should be 120. Always throughout pregnancy, even during labor. This is a very important point, because if you leave it loose at any point of time, then problems will arise. Then, I diagnosed GDM, I gave this treatment, that treatment, but still this has resulted. So we have actually done a continuous blood glucose monitoring during pregnancy, and we have seen the fluctuations occurring, and that repeated fluctuations can result in a fetal problems. So that our OB-GYNs should understand that and monitor, not only diagnosis, monitor the pregnancy is very important. And next thing, we have to go ahead with the prevention of the diabetes by preventing the gestational diabetes.
Excellent. Excellent. It was worth the wait for your golden words, because this is a new thought, the way forward, because the title also is not only from ideas to action, but let's break the intergenerational transmission. So we stop it right at the base, and then, you know, the propagation either to the fetus or the programming we talked about, and the karmas for the next should be, at least, you know, now the handle should be obtained on that. So thank you very much, Dr. Adilakshmi. Before we close with 1 minute video, yes, ma'am.
1 minute. The GDM plate was a very nice idea. So every patient, you know, I just teach them with this DDM plate. But only thing, we should know the diameter of the plate. That is very important, because we have different sizes of plate. So the diameter, so I say 8 inches plate. So we can convert it to centimeter and put it. So that is very important.
Yeah, that's a very valid and a practical point. So thank you so much, Adilakshmi ma'am. And next, 2 rapid questions to Rita and Sheetal. So Rita, the GDM safe, which, you know, which is our trump card. Actually, that has got vitamin D and myoinositol. Okay, so what happens is, though the cutoff is 140, for those who are between 120 to 140 also, we are actually apprehensive when we start giving the GDM safe, so that they will remain under control. The same concept, how much have you kind of, you know, how much the GDM safe comes into your pen the moment you see these kind of readings?
Thank you for asking me that question, ma'am. It comes almost every time, because we have seen a difference with it. And as you correctly said, in that 120, 140 group, we just explain it to them in a very simple way, how we've told you that you have to manage your diet. This is kind of a dietary supplement which is going to work very well in helping you control the sugars. So they really pick it up easily when we say that it is just a nutritional supplement. And it does make a difference when the sugars are not way off the mark. Many of our patients have very good control just with diet control and GDM safe. So I see a very good use of it in the management of
Excellent. The reason I raised this question, Rita, is because Adilakshmi ma'am said that early when you test at 8 weeks, and if it is little bit borderline, and then you can do the diet control, you have to tell a little bit of exercises, maybe you will add metformin. To my mind, I think even before metformin, this GDM safe also goes a long way, because all that we want to do is to achieve the target. And then in a safest way, if we achieve the target, that will be very, you know, satisfying to the clinician also, without any...
It is a nice idea, Hema. We can, for some people, we can put metformin. For some whoever required, we can put myoinositol also.
Yes, because you know that vitamin D and
really helps.
Yes, vitamin D and GDM also is an excess. So both this combination is fantastic to, you know, guide her in a safe way, that we are not crossing our limits going over to medication. If it doesn't come under control with it, of course, the next step of metformin is also anyway in the safe bracket. But, you know, it will be least controversial if we start using this as well. So, Sheetal, how compliant are the patients with respect to PCOS and weight loss when you give them all those kind of diet therapies, compared to the other bracket of GDM and target of blood sugar, compared to the third bracket of post-delivery? You're telling them 101 things, but they're not listening to you. How has been your experience?
Ma'am, first thing is, I would like to say, like, GDM and who come during pregnancy, they are very compliant. They follow all the things. Post-pregnancy, I haven't got anyone back, to be frank enough. But with during pregnancy, they do come and they follow everything very strictly. They do it very nicely. And yes, PCOS and weight gain, when we are talking about, we see that the patients who come to us are whenever they want to conceive during that bracket, or they are teenager and they are going through a problem of obesity because of the body shaming or whatever it is, that not the health reasons, but that category. But the best ones I get is people who have gestational diabetes, who have been diagnosed and who have been told that you go through medical nutrition therapy. They are the people who follow everything sincerely.
Yeah, thanks, Sheetal. Now, Paneer Selvam is also in the picture. The great controversy about metformin and insulin between 12 weeks to 20 weeks. The final opinion from you before I play the concluding video by Sir. Paneer, thank you for joining. You seem to be traveling somewhere, but still you have bothered to join. Thank you so much.
I'm coming from another meeting, madam.
Yeah, no
Thank
problem.
you for organizing this, madam. Of course, metformin we have discussed many times, madam, but in our clinical practice, we continue metformin for some of the PCOS or some of the IGT before conceiving. So far in our clinical practice, we don't come across any adverse effect, madam.
Right.
But the controversy continues, but practically or clinically, we don't come across any adverse effect on the fetus or after the childbirth also. But mother is also protected, madam. In future, the GDM development or the frank clinical diabetes development is much rare or we can avoid. So metformin can be continued even before 3 weeks also, madam. In our clinical practice.
Actually, Government of India has now approved metformin even during early pregnancy. There are references.
Yeah,
yes,
but madam, 12 to 20 weeks, seems to be like one.
No, that is in the guideline. That is in the national guideline.
Universally, they have accepted.
Yes.
Nice guidelines says it can be used during early pregnancy, and Government of India has approved that for the early pregnancy.
Yes, 2018 they have said early pregnancy till 12 weeks, yes. But after 20 weeks also, yes. But 12 to 20 weeks, purposely people are bringing in that controversy in order to confuse everybody, even for the use of before and after. That is what is happening.
Correct.
But now the European guidelines have approved of metformin like Continuum everywhere. I feel that we as obstetrician will tap some of the centers, especially the infertility and high-risk pregnancy centers, where they're not aware of the stoppage between 12 to 20 weeks. They're inadvertently, for all PCOS patients, to be on safer side, they're continuing metformin and without any problem or complication. If we get this group to give us that data, then we will be on a stronger edge to say that this is yet another new series from the Indian context, where beyond 12 weeks also till 20 weeks we have continued, and some of the gynecologist and pediatrician couple, they have an access to the follow-up of the babies also. So if that also we can put our act together and produce that data, I think once for all, this problem also will be a little bit eased out and resolved, because in the Indian context, any day, the oral therapy scores far beyond the injectable and the monitoring that and the hassles that it carries with that.
Hema, one more thing. In Tamil Nadu, thanks to the Dr. Muthulakshmi Reddy scheme, so they are giving nearly 20,000 rupees in different installments. First, second, third installment. Then after postnatally, after 3 months, after they complete the immunization for the child, the last installment is being given. So if they are indexed as GDM people and the baby of GDM mother, then it is very easy to follow up, because before giving the final installment of money, they will make sure that this follow-up is being done. Excellent. So we have to just link it with, as we have linked with the contraception, linked with this GDM also.
I think these are some very excellent, insightful inputs which have come from this great forum. All points which are recorded and to be noted, to be propagated to our community at large, and some clips where I have asked for the messages for the patients as well will be clipped differently and placed on various social media handles which we promise, because the more of the buzz that we create, the more the demand and supply equations are met with, I think it will be a big leap forward to the proper management of wellness of women in general, and that is the whole idea. Chitrakala, can you play Sir's last?
As Sheetal, I just want to add, as Sheetal said already, this is the only period where women will listen to us. All of the time they take care of their mother, father, children, all that. They don't listen to themselves.
That's
now
true.
For the sake of pregnancy, she'll listen to whatever we say, and this is the very short period we can take care of her whole health for the rest of the life.
Absolutely. That is the key point, the key targets that we are focusing. But the hassles of recalling her for ever and ever after, I was telling somebody it's like happily married ever after, like that. Ever after, we have to catch this patient throughout her life annually and do the testing. So we will hit upon some app recalls and some, annually giving them a buzz, or telling in corporate offices that every year your women should have these kind of wellness checkups, etc. I think we will move towards some more innovative ideas to make things happen. Chitrakala, the last clip, please.
Less than postpartum less than may prevent that woman will become GDM. So with this concept we are proceeding now, and fortunately I was able to approach the government of India, Minister of Health, and again fortunately Minister of Health has almost approved this suggestion, and I requested them to start a committee to prevent pathology for diabetes prevention. I hope government goes to call all of us to discuss how to go about and how to convince the doctors to pathology that we can use for the prevention of diabetes. I am sure in the next first step we want on a single step procedure diagnostic. The second step, which I am hoping to do, succeed, will be the concept of prevention of diabetes. Hope will succeed. I wish all of you cooperate with us in this endeavor, and that is my wish and my message to the public and to doctors on this World Diabetes Day, so that we will have soon this country will have diabetes-free generation. Thank you very much for hearing.
So thanks once again to everybody on behalf of the extended family of DIPSI, to which all of us fondly belong, from Team Artist, Team Kasoga and KCOG, Team Shield, Team TNFOG, Team Foxy, Team Figo. It just about needs everybody to put their minds together and believe in themselves that yes, we can, and yes, we will. Thank you so very much. This has become a little like a long-term follow-up, little extended part of the 1 hour program, but it was time really, really well spent. And I can see Balaji there suddenly appearing. So Balaji, you want to close with please thank us.
Yeah, it is a real honor for us to be given this platform, and I thank Dr. Hema and the entire team for giving Shield such a wonderful opportunity. Thank you so much, Doctor.
Thanks, everyone. Thanks for your time.
All will be together with you.
Thank you so much, madam. Thank you.
Thank you. Thank you very much.
Now it's time for us to walk the talk, and so we will.
Thank you. Bye-bye.
Thank you.
Bye.
Namaste. Thank
Bye,
you.
everyone.
Thank you
Heartfelt
all.
thanks. Bye.